Good morning, everyone, and welcome to this session on shifting mindset, new ways of delivering education. My name's Debbie Provan, and I am the chair of Scotland's Digital Nursing, Midwifery and Allied Health Professionals Network, and comprising of more than 70% of the healthcare workforce, maintaining educational content for NMAHPs, nurses, midwives and allied health professionals, has been essential throughout 2020. So this morning's session, I'm joined by a number of colleagues, Peter Glover, Gail Nash, Audrey Taylor, Carol Curran, Anne Ray, who are all from NHS Education Scotland, and also Mark Beswick, who is formerly from NHS Education Scotland, but is now working with Scottish Government delivering the National NHS Near Me programme. I'm also joined by NHS Greater Glasgow and Clyde physiotherapists, Kath Sharp and Ashley Johnstone, and last but not least, AHP consultant from Alzheimer's Scotland, Elaine Hunter. This morning you'll hear a number of pre-recorded videos, the first one being about undergraduate clinical placement and innovation that's taken place to enable students to continue their undergraduate training within the NHS setting despite the COVID pandemic. We'll also hear about how webinars have been developed to upskill the NMAHP workforce at scale and pace. And lastly, how we've modified the DNMAP leadership programme, moving it online and supporting double the number of participants that we would usually have through the programme. As we go through the pre-recorded sessions, please do add any questions that you have to the chat function that we have at the side. If you just add your questions under the session tab, then I'll be able to keep track of those and pose the questions to our panelists at the end of the videos. They're really keen to share their experiences with you, so please let us know which questions you have and we'll go from there. And I'll hand over to Nicola now and she'll take us through the presentations. Thank you.
So good morning, my name is Peter Glover and I'm an Allied Health Professions Practice Education Coordinator employed by NHS Education for Scotland. So I'm going to start us off this morning by providing an overview about how digital technology is enabling student placement provision during our ongoing challenges with COVID-19 disruption, and which in essence is sustaining our workforce supply currently here within Scotland. We're then going to move on and hear about two examples of digitally enabled placements. The first by Kath Sharp and Ashley Johnstone from Greater Glasgow and Clyde, and the second by Elaine Hunter from Alzheimer's Scotland. And you can see here on our screen our Twitter handles, so if you would like to get in contact with us today, we would love to hear from you. So to provide you with some context, in NHS Scotland we recognise 14 different allied health professions, and we also have 7 universities that run AHP pre-registration programmes. Now, as a consequence of COVID-19 disruption across all sectors and also unexpected indemnity insurance issues, we had a 5-month period without any placement provision here in Scotland. Now, these issues have resulted in over 2,200 cancellations, which equates to about 10,300 weeks of placements being lost. Now, on top of that, we have the additional complexity that as of September this year, we have 6 new paramedic programs starting, which will also require placements. So as you can see, the demand for placement provision is higher than ever. So we've used technology in 2 key ways to respond to placement demand. Firstly, technology has enabled us to restart placement provision more effectively than otherwise we would have been able to, and also it's helped us to reimagine and modernise how we provide placements here in Scotland. So a really key and important way that we've used technology is to listen to the workforce. So AHP Practice Education Leads within each of the NHS boards facilitated virtual workshops in which practitioners were able to share their challenges, but also the opportunities that they perceived in placement provision. And they were able to identify that digital solutions were able to address a number of the challenges that they had. We've also used technology to collaborate much more closely here in Scotland, but also further afield. So we've established a placement recovery group, which consists of AHP Practice Education Leads within each of the NHS boards, also representatives from each of the universities, as well as the AHP team within NHS Education for Scotland. And through that group, we've been liaising with and working with our Scottish Government digital lead, but also Health Education England, as well as professional bodies as well. And we've also been linking in with AHPs from Australia as well. So this is a global pandemic. So we have been seeking solutions and working with others further afield. We've also used technology to raise awareness of the importance and need to restart and facilitate student placements, and also sharing practice. So we're going to hear a little bit later on about a successful model by Gail Nash, Mark Bezick and Carol Curran, who were using webinars to engage large numbers of practitioners, and we borrowed that model really to address the challenges that practitioners had highlighted to us. So we were able to share practice from England, from physiotherapists, speech and language therapists, and occupational therapists that were providing fully digital placements down south. And we were able to share those examples and to reassure practitioners here in Scotland. And as our own placement started again, we were able to highlight and showcase examples where that was working here in Scotland, and also were able to share the students' voice as well in terms of what their experiences were. So the situation is that we now have placements being provided in Scotland again, and we also have a large number of digital enabled placements happening. So these are either fully virtual or a combination of face-to-face and virtual placements. And just before I finish up, I just wanted to highlight that in Scotland, we are also borrowing from the University of East Anglia, who have developed a peer-enhanced e-placement, so it's a PEEP. And now that really is contemporary in terms of the fact that it is a fully virtual placement in which students work together in groups with a virtual caseload, and it's delivered through the university virtual learning environment. So we have we've been working with the University of East Anglia, and we've ran 2 workshops up here with universities, and it seems to be very popular. So we're hopeful that we'll be introducing PEEP in the near future. So from virtual placement experiences with virtual caseloads, we're now going to hear from Greater Glasgow and Clyde, who are providing virtual placements, but with real patients. Thank you.
Thanks, Pete. My name's Kath Sharp, and I'm going to give you a brief overview of how we have adapted our peer-assisted learning within the paediatric respiratory team at the Children's Hospital in Glasgow in the light of the COVID pandemic. So we have been using peer-assisted learning for about the last 5 years within the respiratory team at the Children's Hospital in Glasgow, and I've really encouraged the respiratory team to consider how we might improve our practice education experience and how we might enhance that learning environment for students. So we started using a 2-to-1 model about 5 years ago, and that proved to be very successful and very rewarding, both for us as practice educators, and we hope as well for the students who were joining us on placement. So last year, Ashley agreed to go along with my plan to trial a 4-to-1 model to see how we might move on from our 2-to-1 to our 4-to-1 model. My plan for that placement was that by the end of the placement, the students would be running the show. And when I say running the show, what I mean is that they would be leading the morning meeting with the team to make sure that the patients were allocated to everyone and that we would pick up a caseload, and that they would carry the team phone, which meant that they would triage any referrals that came through to the team and decide whether or not it was within their scope of practice to see those patients or whether or not they needed help. And my hope was that Ashley and I would really just have our feet up for that final week, and we would only really be there to help if the students really felt that they to cope with the caseload, and I can safely say that that happened very successfully. Those students were absolutely running the show by the end of the 4 weeks, and we had a really enjoyable time with them. So when Ashley and I reflected on that afterwards, we decided that we would try and provide 4-to-1 placements for placement 1, because we felt that that was a really supported environment for students who were first on clinical placement who've never done this before. And we also decided that they would offer them for placement 7, because we felt that, again, we were offering a really nice supported environment for them to flourish and during that final placement to really make sure that they were ready to join the workforce. However, as we all know, COVID came along in early 2020, and that stopped our practice-based learning for a period of time. We just weren't able to bring students in on placement. And over the summer months of this year, Glasgow Caledonian University approached me and asked if we would consider trialling a completely virtual placement model. And I'm always happy to give things a go. So, and Ashley thankfully never says no when I come and ask her if she would join in with these plans that I have. And so we were working towards offering a completely virtual placement for respiratory. During that time when we were working on that placement, however, we were then able to bring students in face-to-face. So we decided that actually to best meet the needs of the students, it would be much better if we could bring one student in face-to-face each week, but the rest of the students would join virtually from home. And as we all know, digital technology is here to stay in healthcare, and we really need to embrace it. And it was really thanks to that we were able to really adapt and offer a placement model that meant we could give something that was not the same as face-to-face, but certainly a good kind of second choice for that. The placement was primarily made possible because of Microsoft Teams and Attend Anywhere or NHS Near Me for our virtual consultations. The students were able to log in and join that all very successfully, and our placement was a great success because of that. Just to give you a kind of flavour of what a typical morning might look like for our students. So we meet as a team to discuss our caseload and to make sure that we're happy for what the day holds ahead for us, and we had already moved that onto Microsoft Teams, so the students can just join that remotely, and they get to then meet the team. They get to be part of all the discussions and all the conversations that we have as part of a team. We then meet with the students separately after that to make a plan for our day. So we've already got our patient allocation at that point, and we delegate tasks for the students at home to maybe find out some background information on perhaps the condition of the patients that we're going to go and see. And the on-site student then goes up to the ward and gets all the information from the medical and nursing notes so that we've got a kind of full picture of the patients. We then spend some time as a group making sure that we go through all that information, make sure we're comfortable about what our plan is. We clinically reason through why we're getting involved with the patients and what we're going to do. And then we go and see the students. So we take the students that are virtual, come with us on a laptop or a tablet. And the student on site then leads the consultation with the virtual student supporting as and when required. We then meet to debrief afterwards and make sure that everyone's happy and that we understand why we were doing what we were doing and make a plan for the rest of the day. I'd like to thank you very much for listening, and I'm going to pass you on to Elaine Hunter next.
Hello, and thanks, Kath. I'm delighted to be here with you all today to share and talk about our AHP student placements in Alzheimer's Scotland, integrating technology now and in the future. I'm Elaine Hunter, the National AHP Consultant in Alzheimer's Scotland, and I'm sharing the work that Alison McCain and I have developed in partnership with our Alzheimer's Scotland colleagues. We've always had AHP practice placement in Alzheimer's Scotland for the past few years, really to integrate our policy to practice, to support a skilled AHP workforce in dementia care as outlined in Connecting People, Connecting Support. We offered a range of learning opportunities from dietetic students and speech and language therapy students joining our dementia cafes, and also our AHP practice placements for physiotherapy, occupational therapy, and art and music therapy. Then we developed new and emerging digital placement models at pace, but we applied all our previous learning with the added dynamic of the restrictions to our everyday practice that we currently find ourselves. In August this year to October, we had 2 physiotherapy students and 2 occupational therapy students working with us. We decided the way we would do this placement was all home working, because that's how we were currently working within Alzheimer's Scotland, to support people living with dementia and their supporters, and we used a range of digital options, including Microsoft Teams, Near Me, the telephone, animation, YouTube, and social media on the websites, including Instagram and Facebook. All the objectives for the student placement were about self-management, responding to individual needs, connecting people to support and their communities, and also with an emphasis of people who live with dementia and their supporters. So the benefits that we found with this particular model at this particular time was the students developed some amazing evidence-based self-management resources, and that included 14 dementia-aware exercise videos, a suite of activities based on and emphasising health and well-being. They offered 16 one-to-one individual sessions with people living with dementia. They joined 10 carer groups. They posted 85 tweets. They developed top tips using animation to being in placement with us at Alzheimer's Scotland. They wrote 6 blogs and many other amazing projects. The students themselves hopefully had some benefits as well, and this included with a quote that I've added here. They enjoyed joining the carers groups and the individual and tailored projects that they developed, and they also think that the peer aspect of this placement has been a great help. They made a positive impact to people living with dementia and also their supporters, with a quote from a family carer saying, "We all found the experience not as effective as face-to-face in real time, but a valuable substitute, as we were able to interact with yourselves as we worked through problems. Actually, this is the way astronauts have always communicated." And in that particular instant, they were working with Microsoft Teams. So what next? We have 4 more AHP students out with us on placement just now, art therapy, music therapy, and 2 occupational therapy students. And we will continue to work in partnership with our NHS, HP, or HEIs for the long-arm supervision, particularly for the physiotherapy, art and music therapy professions. My background is occupational therapy, so I need support for some of the supervision requirements. We will continue to do peer-based learning, so that sort of take groups of students in smaller groups and allow them to develop projects that are required for the people living with dementia and their supporters. We will continue to use a range of digital platforms. Some great resources have been developed and great opportunities for further support for people. We're just about to test digital art therapy, music therapy, so that's really exciting. We'll get that started in the new year. Our occupational therapy students are going to evaluate our new website that we developed in March this year, called Connected People, Connecting Support Online, with ethical approval for that. And ideally, we'll continue to use the blended approach of digital, and hopefully going forward, we can have some face-to-face contact as well. One of the comments, and one thing that that would have made the e-placement even better for one of the students, was just saying it's greater use of the chats through Microsoft Teams to communicate with educators a bit. So we're always learning, we'll keep learning, and we'll keep asking for feedback from our students that we're working with, and also from people living with dementia, family supporters, and also staff in Alzheimer's Scotland. So thank you very much for listening. And I have one more slide that just gives you all of the Twitter names from the participants in today's presentation. So thank you for listening, and we look forward to hearing your questions.
Hello, welcome, and thank you for watching our video today. The team are going to share some of their learning about the rapid shift towards using webinars to deliver education during the COVID-19 pandemic. The purpose was to support allied health professions to offer their services via a digital platform called Near Me, and to respond to the wider education needs that emerged during the pandemic. First thing I'm going to do, though, is introduce the team. So we have Gail. Hi, Gail. Gail is one of the education staff here at NHS Education for Scotland. We have Carol. Hello, Carol. Carol is one of the project management team, also at NHS Education for Scotland. And we have Mark. Hi, Mark. And at the time of this work, Mark was the AHP Practice Education Lead in NHS Shetland, working closely with Nez. And my name is Audrey, and I'm one of the education team here at NHS Education for Scotland. I'll come to you first, Gail. First question, can you tell us a little bit more about why you did what you did?
Thanks so much, Audrey. And following on from your introduction, these were the questions that we really grappled with at the beginning of lockdown. How would we continue to deliver education to the AHP workforce, which would have to be done in a space? How could we respond to the new and emergent learning needs of our workforce across health and social care during the pandemic? And how could we support AHPs to continue to deliver their services during this time? And all of this with a large and diverse workforce. As we know, AHPs encompass 14 different missions. And more importantly, how could we do that at pace and scale? So that's really where the concept of the AHP webinar series started from. And the initial focus was to support professionals to feel that they had the knowledge, skills, and more importantly, the confidence to use Near Me as a way to support continuity of service delivery. And for those of you who aren't familiar with Near Me, it's a video appointment technology platform. We weren't starting from scratch because we knew that a lot of our services had been using Near Me as an option of service delivery for a number of years, particularly in our children's services. We also knew a number of professions and services across Scotland who had been early adopters as we moved into lockdown. We designed the webinar format to enable sharing stories of good practice from across these services, including lessons learned, things that worked well, things that didn't work well, and feedback from service users and staff. We also wanted to ensure that staff knew where to access the wide range of educational resources which had already been developed by the national team and be able to use these to apply their learning into practice.
Thank you, Gail. Over to you, Carol. Can you tell us more about what you actually did?
Thanks, Audrey. So we responded to the demands from the AHP workforce. We delivered 35 webinars to approximately 14,000 attendees, but we know that some of these attendees joined as teams, so the number will actually be higher. We also had over 10,500 views of the recorded sessions. Of these 35 webinars, 9 were focusing on Near Me for profession-specific audiences, including 1 multidisciplinary and 1 student-focused webinar. 7 of these webinars were run over a 3-week period with over 7,000 registrants, an attendance rate of 75%. And there were around 5,500 views of the recordings of the Near Me sessions. We also had professionals from out with the specific professions joining, as well as attendees from outside Scotland. We're a team of 4 who were geographically separate, but we pulled the webinars together using a mix of digital tools. We used Microsoft Teams, GoToWebinar and Trello while we were all working from our respective homes. As well as this, we realised that we needed process and structure, which we're continually refining and developing. We found peer-to-peer sharing was an incredibly powerful learning tool, and we developed a checklist to support our process, developed speaker guidance, webinar template to gather the information we needed to host the webinars, a webinar presentation template for consistency in approach and to support accessibility. We also created social media engagement unique to each webinar. That was pre, during and post webinar, and we found that this extended the reach of the webinars and encouraged further conversations and reflection. Our structures and process were used by NHS Education for Scotland to develop their guidance around large group teaching. And we delivered education to the Practice Education Leads Network and team to build capacity, and we're currently offering shadowing opportunities to share our learning.
Fabulous. Thank you, Carol. Mark, over to you and the million-dollar question. What difference did it make?
Thanks, Audrey. Yes, and good question. So we realised that from the polls, we were getting good feedback from our webinars, interacting with a great number of AHPs, but we wanted to see, what was the impact. And we evaluated the webinars using 2 surveys we gave to people who'd attended 4 weeks and 8 weeks post-webinar to establish whether the webinars could successfully offer an effective educational experience with resultant increased knowledge, confidence and subsequent impact on service delivery. Initial results from webinars show that 94% of the 321 respondents reported their knowledge of Near Me had improved as a consequence of attending the webinars. The follow-up survey showed an increase of 85.5% of staff using Near Me 8 weeks post-webinar. So the webinars not only demonstrated learning at the point of webinar, but also the application of that knowledge into practice post-webinar, as we can see by the figures I'm going to quote to you now. So Near Me appointments were roughly 300 a week in March this year. Early in November, we hit 18,000. So it's a massive uptake across all health and social care services. Now, AHPs are consistently in the top 5 for these figures in monthly. For example, in October, physiotherapy was 3rd and speech and language therapy was 5th. Physiotherapists had offered 5,422 appointments. Speech and language therapy had offered 4,064, and dietetics had offered 1,231, and occupational therapy 953. So the above show that AHPs have been consistently offering near me as a choice for their service users.
Thank you, Mark. We're going to round off now just by asking each of you just to give us your one headline message from the during the pandemic and the summer. So Gail, I'll come to you first. What's your one headline that you'd like to share?
I suppose my key learning was the importance of just giving it a go. We knew this was urgent. We knew that we didn't have luxury of months of planning to get everything perfect. It just had to be good enough, and we just pretty much jumped in. We used QI methodology to support this, creating process and structure to support the work, undertaking rapid cycles of change and ensuring spread. This allowed us to be really flexible and responsive and to engage effectively with a large volume of the workforce.
Thanks, Gail. Carol, what's your headline message or key learning?
My takeaway, Audrey, is it was fantastic working in an agile way in a dynamic team. This meant we collaborated, we were empowered, we worked transparently in a non-hierarchical way, and we worked together with a burstiness mindset, which let us improvise and create the webinars in an encouraging and supportive environment.
Thank you, Carol. And Mark, your thoughts, your final message.
Yeah, I'd just like to share how powerful peer-to-peer learning is. People sharing their experiences, what had worked well, what had struggled with, and how they'd overcome that. And that sharing enabled people to come and think, oh yes, I could do that in my work, and go ahead and put it into practice. And that's been demonstrable, you know, with the figures that have been shared with you today. Thank you.
Fabulous. Well, thank you all very much. And the team will be part of the panel that will be happening a bit later, so they'll be able to answer your questions or respond to comments. But in the meantime, thank you for watching our video.
Hi there, it's nice to be speaking to you today. I'm going to be speaking to you about the NMAHP Digital Health and Care Leadership Programme and how we have changed the programme in light of the COVID-19 pandemic, and also how we're scaling up to meet the current need for people who are interested in attending. My name's Anne Ray and I'm Principal Educator, and I've been leading this programme for NHS Education for Scotland since 2014 from the very outset. So it's always a joy to be involved in this. The programme, as I say, is led by NES, but it is very strongly supported by the Scottish Government. It's funded by the Scottish Government, and we work really closely to make sure that we're meeting the needs of the service. We also have a large number of people who are involved in the programme, both in speaking and in supporting, and we couldn't really do what we do without all of their support. So it is truly collaborative and enjoyable. Everybody who's on the programme becomes a digital champion, and there's a nice little badge to go with that. I'll tell you a bit about the programme first of all and bring in highlights of how we're changing it. So it aims really to maximise the potential of technology to benefit service users and staff. And it's really key is about its leadership programme. It's making sure that people who are on the programme have the skills to be able to influence and use digital solutions in health and care. And that is pretty challenging in some situations. And so the leadership elements are really quite crucial. So in terms of impact of the programme, what happens is each of the participants undertakes a digital improvement project. Now, these could be things like supporting self-care or prevention, looking at different ways of working in a virtual way, perhaps looking at virtual consultation, and and also perhaps looking at data to drive improvement. So these are some of the examples. Now with COVID-19, we re-emphasised the focus of applications and asked that people were looking at ways of supporting recovery, rehabilitation and new ways of working. So this is a slightly different approach and is one that addresses the current pandemic. Cohort 14 started in October, and when we advertised for it, we actually had around 100 applications. This caused us some concern because obviously we wouldn't want to be turning people away who had good ideas, but we were able to identify that quite a number of people were focusing in on specific areas. So what we decided to do was to offer those people a bespoke programme. So we had the leadership programme pretty much as it stood previously, with some changes which I'll tell you about. And then we had these 3 specialty groups. So remote monitoring, in this case we're looking at in healthcare. Another group were interested in virtual consultation. For this purpose of this, it's NHS Near Me. And also a number of people who were wanting to develop some sort of education resource, whether it was for patients or for staff. So this has enabled us to meet the needs of more people, and we certainly intend to do the same into 2021-22. We certainly are also scaling up, and we intend to take up to 200 people in next year. So we'll use this similar kind of approach. The programme is now delivered completely virtually. We did have some face-to-face sessions before, and we've also identified that need to really have increased pace, and we've therefore decreased the programme from 9 months to 6 months. I have some pretty amazing speakers from the Scottish Government, from NES, from the boards, from special health boards, from out with the NHS, and really trying to look at technology enhanced learning. So trying to support our speakers and our participants to learn in that virtual space. I'll show you a slide in a moment around about some of the work that NES is doing around technology enhanced learning, which might be helpful to you. So we're looking very much at asynchronous versus synchronous. So we have that flipped classroom idea where you would have some presentation of podcasts and reading material which would be undertaken before the session, and then that means that the actual time that the participants are virtually together, then there is an opportunity to have discussion. And we see very much that need to have the programme is about social learning. So being in peer support groups, having breakout rooms, using social media, having a community practice, and also we have the NMAHP leaders group who are providing support increasingly so. And certainly looking at all different platforms. It's a safe space, we can test different things out. If they don't work, it doesn't matter. So really trying to use the programme as experiential learning. This is the slide I mentioned to you, and it's the guidance for educators, and there's the URL there if you want to have a look at it. And there's a really good SWAY presentation, which is around about transferring face-to-face training to online delivery. And I would recommend this to anybody who's an educator supporting learning, because it just really gives you some ways of actually engaging in a virtual environment. So one for you to maybe have a look at later. The participants of the programme are from health, social care and the third sector, and are largely NMAHPs, although we do have some tech leads and also some healthcare scientists. We are certainly looking at expanding the target audience to reach more of a multi-professional audience, and we'll be exploring that in next year. Just for those who are interested, this is the general content of the programme, and each of the sessions address particular aspects of digital health and care. And the outcomes from each of the projects is shared at consolidation events. Now that we've moved virtually, these will just be half-day events, and we'll also look at different ways of sharing the successes. So it may be presenting a poster, writing a blog, doing a podcast, doing a presentation. So a number of ways, and we'll be advertising that so that people can link into it if you would like to. Okay, so just a quick summary then, highlighting our commitment to digital health and care, looking at employing different virtual technologies, and we'll continue to do so to make the programme even better. We have responded to COVID-19 by focusing on recovery, rehabilitation and new ways of working. We've already scaled up delivery, and we intend to increase that in 2021 with up to 200 participants, and we'll explore multi-professional delivery. So cohort 15 will be advertised in January and will start in April next year. And finally, here is the community practice. The URL is there, and the impact section is highlighted where you can go and find out the outcomes of all the projects. Our email address is there, and also our Twitter handles. Thank you very much, and I look forward to any questions that you have.
Thank you very much for your presentations. Just a reminder for anyone that's joined the session a little bit later and maybe missed the start. My name is Debbie Provan, and I'm the chair of the Digital Nursing, Midwifery and Allied Health Professionals Network in Scotland. I'm just going to give my panellists a couple of seconds to rejoin the session. And then we will put your questions to them. So if anyone has any questions following those presentations, please just put them in the chat box to the right hand side of the screen. You'll see that there's a session tab, and if you just add your questions there, then I'll be able to put those to the panelists. Thank you all. We've got one question that's come through from Andy Bleeden on the chat, and Gail, it sort of refers to your sort of key message, which was about giving it a go. And Andy's asked, what tools have you used to try and bring people on board who perhaps don't want to give it a go, or perhaps maybe feel that they're unable to give it a go?
Thanks, Debbie, and thanks, Andy, for that question. Yeah, I think when we were really thinking about how do we get that information out to people, we really took the tack that we're just going to be really open and honest. We're going to share stories, we're going to share pitfalls, really to try and inspire people to think about how they could apply Near Me or use Near Me to continue to deliver their services. And that was one of the reasons we went down a professional route, so that professions felt that they could connect with hearing from other people from their profession around what they had actually done in terms of rolling Near Me out. So yeah, I think it wasn't anything rocket science. It was really just been around how do we engage, how do we be open and honest, and acknowledge actually that it was difficult, and we were all learning together. I think, Mark, you might be able to share some things that you did from a kind of very operational clinical perspective.
Yeah, I mean, pretty much that on the ground translated into basic hand-holding and practice sessions. So for myself as a clinician supporting my local colleagues, it was very much around them being the patient, coming into my clinic, seeing what it was like for the patient, what their experience was like, and then switching that around. So then the person then opened their waiting area and I came in as a patient. And often once people have had a go once and they understand that it's a very easy thing to use, and they start then to think, oh, I think I could use this with this type of patient, maybe not that type of patient. And I think it's just exploring what are the advantages, what are the challenges, what's it appropriate for, how can it save you time, how can it be a better experience for the patient. So a lot of those kinds of things. And I think when clinicians start seeing feedback or outcomes from patients related to what they come to work for, that's when the light bulbs start to go on and go, actually, this can be used, and it is. So, and often it's your local champions, your local peer support groups. So investing and fostering those people within your networks has been a very powerful thing. So taking that national view and looking at using a similar concept, but locally hand-holding and doing, being alongside people exploring this.
Thank you for those insights. I think it was something that was in the back of my mind as I was listening to your presentations, and particularly in relation to that from Ashley and Kath. Thinking about student training, and as Pete sort of started off by saying, you know, there's a number of weeks and months and hours that have been lost as a result of the COVID pandemic to undergraduate training. And I think that I would imagine that there are some sort of underlying fears from our clinical community about the quality of student placement and whether or not students are really getting those experiences that we would hope that they normally would whilst on placement. And that might be one of the reasons why people are scared to give digital sort of virtual training a go. Can you reflect on that and share your experiences with me? Do you find that now that you've given an example of how practice-based education can be delivered successfully, that your colleagues are more willing to get on board and give it a go themselves? Don't know who wants to start, whether Pete, Ashley or Kath. Feel free to jump in, and the same to Elaine and Ashley, because I'm sure there's similarities and slightly different perspectives on that.
Shall I go first? I'll go first. So that was a couple of, when we did our initial engagement with the workforce, that was some of the concerns about what is the quality of the learning environment going to be, what's the impact this going to be for students, and also students were telling us as well that, you know, they were concerned about what does this mean for us when we graduate as well. So so we have done some work in terms of that, in terms of aspects about employability, and we've been looking at, you know, what is able to be provided through virtual placements, and really what we've found is that virtual placements are actually able to provide a more rounded experience in terms of the skill set that students are able to develop. So we talk about, within NHS Education for Scotland, we talk about the 4 pillars of practice, about building a workforce and a transferable workforce. And what we've found is that virtual placements are able to provide students more opportunities to use their clinical skills, their education skills, their research skills, and their leadership skills. So that's actually heartening in terms of us trying to produce graduates that are flexible and dynamic and able to respond to different practice settings. And I think some of the examples that Elaine and Kath and Ashley have been sharing really highlight that. So I don't know, Kath, what have you felt has been the kind of the pros and cons of virtual experiences versus the kind of face-to-face aspects?
Yeah, so I guess from us, we've had a very positive response from our students, and I think some of it is around the fact that they are keen to just get out on placement at the moment. So I think they are. So we've got a bit of a willing audience from the students' perspective, in that they are just grateful that there's opportunities because it's been such a long time since they came out. And I think I think the thing is that all these technologies are here and we use them, and they're going to go into a clinical environment where all of these things are expected to be used. Some people have embraced it more than others, and I think you're always going to get that. So I think the people, like Mark was saying, the people that want to go with it, you use them as your early adopters and try and just get other people to get on board. And to echo what Gail says about using the webinars, I'm a big believer in just do it, just try it, you know. And I would say that if people think that they can't do it in their environment, find someone who's done it and see if they can help you problem solve how you can use digital tech, or even if it's just a multiple model. Think about it's possible, I think, in any clinical setting. You just need to problem solve. And I think sometimes when you're in it delivering that service yourself, it's hard to take a step back and see how you might be able to do it differently. So sometimes someone else's eyes might be able to just help you move forward with that. So yeah, I think the more we can share and the more we've got networks to let people talk to each other, the better it'll be.
I think just picking up on that as well, we were very open and honest with our students, especially our first 4 students that came along, in that Kath and I have experience of doing multiple model placements, and that we had done face-to-face on-site placements with 4 students at a time previously. However, we were very honest with our students to say, this is the first time we've actually done it virtually, okay? So bear with us, we're all in this together. And our students were fabulous at working with us to work out their technology skills were far better than our technology skills. And we came together as a bit of a team to make the placement work. And at the end of our first placement with our 4 students, they came up with a beautiful top tips guide for all our future students that came through that we've used. And our students keep adding to that as time goes on. So I think it's just being honest with the students and coming together as a team to help to make it work. And we've been very fortunate now in our whole respiratory team here at part of the Royal Hospital for Children have agreed that now that they have seen how this model can work, they're all happy to take it on as well.
I think you make a really interesting point there, Ashley, about how digitally enabled some of our students actually are and how much we can learn from them perhaps. And I think, Elaine, I'd be really interested to bring you in on that, because I think the examples that you gave of students talking about sort of using social media and supporting you to communicate with people living with dementia and their families. And I guess, you know, could you share some experiences on that and how we can maximise our reach and our impact on the clinical services that we provide through student training and the skills that they've got?
Yeah, I mean, I think what we did in Alzheimer's Scotland is the students were amazing. They were incredibly innovative. If anything, we had to say to them, sort of slow down with your projects, because they got hold of the technology far quicker than even sometimes I have as well, actually. And I think what we did, because it's third sector, is really relate to them and talk to them actually that the platforms we use are exactly the same platforms you will use when you go and work in the NHS, or if you go into private practice, whatever you choose to do. I think what worked well for us as well, because I am an occupational therapist with the physiotherapy students, so we worked really closely with Claire, Craig and NHS Ayrshire to be the long arm supervisor, so that worked really well for us, Debbie. I guess when we're using the social media, we're really clear what the purpose is. It always goes back to the objectives. So it's always about self-management information and hints and tips, and really that universal offer. And what we're really clear about in third sector, we're not offering statutory services. We're not offering specialist physiotherapy. We're offering self-management advice and help. And like sort of Kath and Ashley were saying, being really clear in the objectives. I think the only thing I missed, which is why I said at the end, is actually just sitting in a room with the students and having a blether, what their weekend was like, what their life is like outside of work. So we built that in as well, actually, because that's the bit we didn't see them. I couldn't even tell you how tall they are because we never saw them. And I would hope once we're through the major pandemic, I can maybe meet with them later on. But the projects they've left behind are phenomenal, and staff within Alzheimer's Scotland are still using them. And I think really that impact, that one quote I gave of that family carer, they were great working with the people. Which is really important for us as well, actually. So I think being clear on the objectives, we did link it back to policy and practice, and develop those objectives with the students. And then they thrive within the environment. And then working with our colleagues within NHS, which is critical for the professions that I'm not.
And I'd like to bring everybody in on that and maybe get some reflections from Anne as well in relation to exactly what you just said there, Elaine, about the value of sort of face-to-face and building those relationships. And again, Mark, in your Near Me work, I think that it's been incredible to see how many people have embraced that and how many consultations are being delivered through Near Me. And I've heard some nice anecdotes from people that have said that in some respects they like Near Me because they can see the person's full face, whereas when they're in a clinical setting and they're behind a mask, you don't get to see the smiles that you maybe would over a virtual environment. But what have we learned, and thinking about the sort of reflections that you're hearing through the DNMAHP leadership programme, and what are people's fears about using digital within their practice, and how do we move and maximise our impact of education, whether it be to fellow professionals or students? We don't just, do a presentation that we would normally do live on a computer. How do we think about all the other elements and make the most of those?
Yeah, thanks, Debbie. I think that one of the strengths of the leadership programme was that ability to join up and meet people and chat and have coffee and lunch, and so that was really important. So I was quite worried when we were moving to entirely virtual, but actually having some of the functionality, for example, being able to do breakout rooms and just putting people into small groups, then I felt that kind of really helped that building those relationships. And I actually think it's fine. I think that one of the benefits is that people who are in Highland and Grampian, Dumfries are not having to get up at 5 o'clock in the morning to be able to travel to have a session in Edinburgh or Glasgow. So actually it feels a more even playing field, that everybody's coming in, they've actually had a coffee, they're feeling quite relaxed, they've not travelled for 5 hours to get to the session. And then by putting in those breakout rooms where they can chat and build relationships, I think it's working. I think it's okay. I do think that the applicants to the programme tend to be people who are actually a bit digital savvy. So we're actually getting people who are fairly comfortable in that environment. So I think it's a good example of how people can have a chat and a conversation, build a relationship within a virtual space. But I think that we need to practice a bit more with people who are less comfortable with that environment.
Yeah, and I think that's an interesting reflection. And I guess the stats that Gail and Mark have relayed in relation to the number of people that have gone on the webinar since, again, is maybe one of the advantages of this type of delivery method, is that for those that are maybe not so digitally savvy, that they have a suite of resources available to them that they can tap into at a time that's suitable for them. So Mark, I don't know if you want to go back and say a little bit more in relation to the question that I'd posed to Anne, but also thinking about bringing all of you in about how people can tap into some of the resources that we've created throughout the COVID pandemic.
I think the element earlier you touched on around there's sort of some fear amongst some clinicians that might miss something on the video rather than seeing someone face to face. And I think exploring that with people has been important, and to increase confidence. And we've done some good stats around minor injuries units where people have had given self-management advice, and the footfall is reduced by 45%. And of the 7% of people that came back because their condition worsened, which is what they're supposed to do, but everybody else was managing at home. So there's some really good data where people are making quite complex clinical decisions using digital resources. And I think that the key thing is to give patients choice. We can't assume that every patient with a certain condition, video is going to work for them. They might prefer the phone. They actually for that patient, face-to-face is going to get the best outcome. So we want to make sure we're not limiting choice for patients. We want to make sure we're offering choice. Digital is one of a suite of things. We've still got the phone, we've still got face-to-face in certain situations. So I think it's being making sure we still give choice in there. And just picking up on your point about travel. So just to give you some data on that, we just passed 500,000 near me appointments in October. Now, the question that goes out to people post near me, ask them how much they would have saved in travel. The average is about 13 miles each way. So that's 14 million miles have been saved of people traveling, which is quite amazing in the life of near me in the UK from 2016. But also from the environmental perspective, that's massive as well for Scotland. So another reason to embrace digital as a choice for patients.
And Gail, just to bring you in on that, and we were talking about access and resources that are already out there. And you mentioned in the presentation about shadowing opportunities and being able to share the learning. Can you tell us a little bit more about that and how people can make the most of your learning and the resources now and in the future?
Yeah, thanks, Debbie. I think that was one of the aims of the webinars, was not only to provide an education session, but also to ensure that people knew where to access resources. I think it's often a criticism that lots of resources are developed and people can't find what they need, and so we really made that one of the aims of the webinar, was to ensure that people felt that they had the tools and resources at their fingertips. And certainly with the Near Me team, I mean, there was fantastic resources there, but we just needed to make sure that our workforce knew where to find those. In terms of our shadowing and how we shared our learning, I think we realised fairly quickly that although this was we were able to reach a massive proportion of our workforce and beyond our workforce, that it was, it is quite labour intensive. We developed what we think was a fairly slick system, and it's actually really interesting being on the opposite side of that today. And I think you guys will all know what I'm talking about, but there is a lot of investment and time required, and we needed to make sure that initially it was just a small team of 4, so Mark, Ailey, Carol and I, but we knew that we weren't able to sustain the kind of level of webinars that we were delivering. So really reaching out to our practice education network, to our internal colleagues, to ensure that people felt skilled, both in terms of facilitating online, because I think that's that people had to shift that really quickly, and we knew that people who are really experienced educators delivering face-to-face training, that shift onto delivering at distance was quite difficult. Some people just, it wasn't a safe space for them, and so we needed to ensure that people felt confident around delivering at distance, but we also needed to make sure that people understood the platform, and those were 2 very different things. So we offered we've been offering shadowing. So as Mark was saying, that real hand holding, let's bring people along that are maybe interested or maybe not, people who were really anxious. We went at their pace. We delivered sessions. We set up test sessions where people could get in and play about with the platform, and we also delivered principles of online facilitation, things that you need to think about when you are delivering to large groups of learners. So really what we've managed to do is start to build capacity and create a cohort of people who feel confident to deliver the sessions. The other thing, just lastly, and it was part of our real quality improvement methodology, so to ensure that we had consistency in how these were being delivered, we developed guidance for speakers, we delivered checklists for ourselves, so we've got a whole suite of resources that we're currently pulling into a toolkit that will be available to help support staff who want to deliver large didactic teaching sessions.
And can you tell us where they'll be available? How can everyone get their hands on them?
Yeah, so there's a number of places at the moment. We, at the beginning of the pandemic, developed an AHP learning site on Turas, so a lot of our our recordings of our webinars are there, but it's also a part of a bigger piece of work that's underway at NES around technology enhanced learning, and it's already put up some of the guidance, so guidance for educators, that includes sways so they really are covering small group teaching, large group teaching, and they're all already available on Turas.
Brilliant, thank you. And Pete, do you want to give us a little bit more? I can see you've put some comments in the chat there about sort of localization and sort of local workshops and things like that. Do you want to explain a little bit more?
Yeah.
So what we've been doing with, I mean, obviously we're a small resource, and the HP Practice Education Leads and the board are a very small resource. So yeah, what we've been doing thus far is been trying to do what can we do at scale and reach to support people. So, you know, the webinar model about that Mark and Gail have been talking about, and then we've been developing central resources to give some guidance and reassurance for practitioners. And really what we've been trying to do is share the examples from Ashley and Kath and people like Elaine to inspire people, to reassure them. But that's kind of that's at the top level. What we're trying to do now, or what the next step is to take those principles and take that problem solving that people have been doing and dropping down now so that we're having more facilitated local conversations. But that'll all be done virtually, and helping people to see this is what's going over in one area, how can we operationalize that locally. And one of the key challenges that we've got is that information governance requirements are quite different across the board. So an exact solution in one area isn't necessarily transferable. But what we're working on is that we're going to be having, through the HP Practice Education Leads, connecting practitioners that are already doing innovations to help them to understand how they can start to provide digital and virtual experiences. So basically taking the principles and resources that we've got nationally, but dropping that down locally, and how can that be applied locally. And it will be different due to things like information governance requirements and things like that.
And I think, Anne, you had sort of commented as you were speaking there about the skill set of the sort of practitioners that are on the DNMAP programme. And I'm thinking about, again, those that are maybe a little bit slower to follow, and how we, and also the fact that we had an infrastructure already in place to be able to, you know, modify and really scale up rapidly. So going forward, how can the other professions that aren't already in DMAP with all of those structures, how can they learn from our experiences and the resources that we've got available, and how transferable are they, do you think, to other professions?
Well, if we're looking at the Digital Health and Care Leadership Programme itself, of course, it started off in 2014 about NMAP, so nurses, midwives and HPs. And that was because there was a need. There was a need to upskill that particular group of staff. And to an extent, that still exists. We have a need to continue with NMAPs to develop their skills. Now, there has been interest from other professions. We do have some places for tech leads who may or may not be nurses and midwives, but they're tech leads. And we also got healthcare scientists on the programme. And that's just been a sort of negotiation thing. We have had other professions, so we've had dental tutors and we've had pharmacists. And that's more around about trying to see, does the programme fit for them? So what we, it does fit for them with some tweaks to actually ensure it meets their particular professional issues. But at the moment, what we're doing, we continue with NMAP and tech leads and healthcare scientists. We continue with them, but at the same time, there has been a proposal into the government. We probably will be developing a multi-professional programme, and I guess there will be a lot of the elements of the NMAP programme that will be offered as part of that. Still discussions going on about it, but I'm fairly confident that that is going to be available fairly soon. So in terms of, does it meet the needs of multi-professionals? Actually, yes, it does. And it's just around about where's our target audience for delivery.
And you have the community of practice. I don't know if you're able to share the link to the DMAP Leadership Programme Community of Practice just on the chat, which I think would enable people to perhaps see who locally has been on the DMAP programme. And again, it might just provide an opportunity for them to get an idea of the types of projects that are completed and the type of skill set that they've got within their NHS board that they could perhaps be tapping into and working collaboratively on, which made me think as well about Elaine and the fact that you sit within third sector and the fact that you are providing practice placements to students. And I'm wondering, do you think that the introduction of sort of digital and the fact that there's more of a focus on digital in relation to practice placement. You've obviously talked about some of the things that are not as ideal in terms of building those close relationships with students. But do you think there is an opportunity for us to perhaps work better across sectors now that we are focusing a little bit more on digital enabled practice?
I can only speak on behalf of Alzheimer's Scotland, but I think if you, as HPs, even in the boards or as NES, approach other third sector organisations, the benefit of having access to HP students has been phenomenal in the third sector. And I know, I mean, most of the third sector in Alzheimer's Scotland, then we use exactly the same platforms that everybody else uses in the NHS, and we stick to the same governance. I think I know my colleagues in Alzheimer's Scotland are presenting or already have in this conference, but the developments that third sector are making around the digital offers is phenomenal as well. So we have a digital resource centre in Alzheimer's Scotland being developed, and in there we hope to have an EHP room. So some of the projects the students have started, particularly around self-management, we can put in these rooms. We've got an app as well. So I think the partners are there. I think what we need to work with is actually particularly around the supervision, so that long-arm supervision, and working with NES colleagues as well, just to make sure we've got that support. Some of the placements don't need an HCPC HP to supervise them, and others do. So hopefully that answers your question, Debbie, but I think there is an untapped resource there. And there's some learning that we can share from third sector. We've also got the examples as well with Pamis and Jenny as well, and that work that's been developed. So I'm not the only area that's taken students within third sector.
Yeah, I think that's great, and certainly useful to keep in the back of people's minds, I think, as we go forward. And Kath and Ashley, obviously you've given your experiences of how you're supporting students to come through their undergraduate training. But I guess as clinical practitioners on the ground, what kind of learning resources have you tapped into during COVID? And how do you think your practice will have changed forever, hopefully, going forward? What have been the positives coming out of this?
Yes, I don't think we'll ever go back. So we've made use of all the webinars that Mark and Gail have been running and tapping into that. We were very fortunate that we were actually set up using Near Me prior to COVID. So we actually already as a service were starting to introduce more virtual consultations, which obviously escalated hugely when we were unable to have our patients coming into the hospital. So I think there is an element of we have just got on with it and given it a go, as we spoke about later. However, we have embraced the opportunities and the resources that have been made available to us as well.
From a placement model perspective, while I know the students would like to be in face-to-face, I think for us the value, especially for the other practice educators in the team, Ashley and I were all for developing the 4-to-1 model, and we're going to do that anyway, even if whatever happened. Some of the other practice educators are just a bit hesitant about, they're happy to do 2-to-1, but to go beyond that is a bit of a challenge for them at the minute. But what a couple of them have said to us since having done it this way is that they quite like doing it this way because they feel that they can manage the placement themselves better and they're facilitating learning much better. And for the students, the way that it's set up with the students, the fact that they're supporting each other and bringing lots of information together all at the one time, it means that they're getting a much rounder picture of the patient much earlier on, that if they were all doing that themselves individually with patients, they wouldn't get that. So I think even if we get to the point where we're allowed to bring more people in face-to-face, I'm not sure that we would opt to do that. I think we would still, or we might have more of a flexible balance with that, where we would still stick with what we're doing. I think it works really well for both the practice educators. It allows them to build up the skill of doing multiple model placements, as well as the benefits to the students.
I think that's really interesting. Absolutely, Gail, on you go.
No, I was just going to say, just building on what Ashley and Kath have said, and I think Pete mentioned it earlier as well, that there were specific webinars around practice-based learning where we had students, we had clinicians sharing their feedback, and again, being able to share that at scale. And I think for me, certainly being behind the scenes on the webinars, listening particularly to the students around how positive their experience had been, I think was really mind-blowing for a lot of people. We had students saying, this was the best placement I've ever had. I can actually see, what it would be like going back to the old way of engaging in placements. And actually our clinicians were saying the same. I mean, we had examples where clinicians were being able to have huge amounts of students. They had students who were from overseas. So we heard last week from students who had gone home at the beginning of the pandemic, but that were still able to engage and finish their placements and graduate, students from Australia, students from Canada. So really, just really exciting times. And yeah, just wanted to highlight that. I also wanted to highlight how amazing our clinicians are in NHS Scotland. I think we were blown away by people stepping up. And we were delivering the webinars to 500-600 people, some to over 1,000, and our clinicians have been, as educators, absolutely phenomenal. So really, just a huge thanks from us to them, because we were really just running the webinars. It was actually hearing from the clinicians that I know Debbie, that was really just amazing. So yeah, a platform has enabled, it has really opened up a whole new world for us.
Pete, did you want to come in on that as well?
No, just to say, I was just agreeing with everything Gail was saying. I was just, we have really been blown away, and and certainly this, because of COVID, I've been using this phrase, but we've all had to change our mental model about what is practice-based learning and what is contemporary practice, and this is where students are going to be working in the future. So yeah, no, I've been really inspired by the workshops as well. I mean, when you've got students in Canada able to complete their programs, do you know what I mean, and have placement alongside their peers that are also in Scotland, it is amazing. So the digital era is definitely, well, it's not for everybody. It has definitely been a leveler and has increased accessibility to certain things. So the innovations that Gail was saying, I mean, we have been blown away by the practitioners, and people doing 4-to-1 models and then projects in amongst that, and then having one person in and 3 students external. It's been amazing that all this innovation is going on, because traditionally in Scotland we have traditionally been stuck to each profession has their own toolkit of how they provide practice-based learning, and all of that's kind of been blown out of the water. So it's been an interesting journey, and really inspiring to hear what practitioners have been doing, and just been great to support them to share their students.
We have just 2 minutes left, and what I'm going to do is I'm going to go around all of you and just ask you to give one sort of top tip or key reflection that you would like to relay. But I think I just wanted to say, sort of on the back of Gail and Pete there, I absolutely agree. I think that the clinicians have really stepped up, and they have absolutely embraced sort of digital technologies and all of the challenges that have been thrown at them throughout COVID-19. And I think it's a real sort of testament to the fact that everybody is still engaging in education and the DMAHP programme and all of those other things, but equally a huge shout out to all of you guys within NES and third sector that are again enabling all of this to happen. So I'll do a quick round robin, and I'll start with Kath if you've got one sort of key message or top tip.
Just do it. That's my top tip. Just do it. It'll be fine.
And Ashley? And I cut you off. I wanted to come in.
My tip would be to do it together as a team, and work with each other, and those who have been there before, and even for us, speaking about our student model, work with the students, and you'll have a far better outcome at the end.
Thank you. And Elaine?
Sort of find your friends, find your partners in third sector, look to them to offer and fill the gap for some of the placements. We can offer some phenomenal learning opportunities for our future HP workforce.
Absolutely. Anne?
Yeah, I guess around about that network, making sure that you link in with that. It's an ever increasing network, and many of the people on the NMAHP network have done the Digital Health Care Leadership Programme. So please find out who those people are and engage with them.
Thank you. Mark?
Just to reassure the Scottish workforce that we are streets ahead of many other countries in terms of embracing digital solutions for patient care. So we are viewed as kind of like, what's the word? Anyway, leaders in this area. And I suppose I would just say, just have a practice. If you're new to using video consultation, just have a practice. I don't know, do me with your mom, anything just to get that first few stages over and done with.
Great, thank you. Gail?
I've said just do it, but Kath's already said that. But I suppose just embrace it and don't be frightened of it. There are so many people here to help. Give it a go and get in touch if there's anything that we can do to support that.
Last but not least, Pete.
Oh, I'm feeling the pressure now. Mine would be we all have permission to do things differently. I think that's been a really key message throughout the webinars. The practitioners have been shaping student-based learning to their settings and on their own terms to provide what they can. So we all have permission to do things differently now.
Thank you all. I very much appreciate you being here with me today and sharing your experiences, and I'm sure that I can see from the chat that there's many others that are offering their thanks. So thank you also to the DigiFest team for supporting us to share our experiences and our learning, and I hope the rest of today's sessions go well. Thank you all.